Hello everyone. Let me first introduce myself. This is Dr. Hamouda Ouanassa. I am an Associate Professor of Parasitology-Mycology at the Department of Medicine, University of Batna to Algeria. Today I'm going to present my work entitled Epidemiology of Systemic Candidiasis in High-Risk Departments at the University Hospital and the Anti-Cancer Center of Batna, Algeria. Introduction. Invasive mycosis are opportunistic infections responsible for significant morbidity and mortality in hospitalized patients, 40%, which has led to a significant additional cost of hospital stay. Among its invasive mycoses, systemic candidiasis come first in view of their frequency, which is increasing in favor of other infections. Candida represents 70 to 90% of all invasive fungal species. It's the fourth cause of owl sepsis in the United States and the seventh cause in Europe. Systemic or invasive candidiasis, which corresponds to the presence of a yeast of the genus Candida in a normalist trial site. Systemic candidiasis includes several clinical varieties. Candida septicemia or candidemia, defined as infection proven by the presence of one or more positive blood cultures for Candida, and the disseminated candidiasis, which corresponds to the presence of Candida in at least two non-contagious organs or sites, most often secondary to hematogenous dissemination. Systemic candidiasis mainly occurs in patients hospitalized in departments accommodating immunocompromised patients. Objective. The aim of this study is to describe the epidemiological characteristic of systemic candida infections in high-risk departments, identify and analyze the risk factors for the occurrence of systemic candidiasis, show the value of the colonization index in the occurrence of disseminated candidiasis, describe the distribution of the candida species found, estimate the death rate. Type, scope, and period of the study. This is a prospective descriptive bicentric study carried out in the University Hospital Center and the Anti-Cancer Center of Batna, Algeria. The study was carried out over a period of 3 years, from January 1st, 2016 to December 31st, 2018. Patient recruitment. Our study focused on all patients of both sexes hospitalized at the University Hospital Center and the Anti-Cancer Center of Batna, Algeria during the study period, whatever the service and the reason for hospitalization, age greater than or equal to 16 years, having undergone at least one deep sample from a normalist trial site sent to our Parasitology-Mycology department for mycological analysis. The inclusion criteria were included in our study all the patients having at least one deep sample positive for Candida by direct examination or in culture. Each deep positive Candida swab is considered a proven case of systemic candidiasis according to the diagnostic criteria of the European Organization of Research and Treatment of Cancer. The exclusion criteria were excluded out of our study: patients hospitalized in the neonatal or pediatric ward, patients with positive deep samples from yeasts other than Candida, patients with negative deep samples, patients on prophylactic antifungal treatment. An information sheet was established for each patient included in our study had proven systemic candidiasis. Data collection focused on patient demographics, mycological data, clinical data, therapeutic data, the evolution of the patient. Materials and methods. All patients suspected of systemic candidiasis underwent one or more deep swabs depending on the patient's clinical context. blood cultures, cerebrospinal fluid, peritoneal fluid, joint puncture fluid, biopsies, valve vegetations. All the patients having at least one positive deep swab for Candida, therefore a proven systemic candidiasis, systematically benefited from 5 superficial swabs, buccal, rectal, or saddle, urine, nasal, and auricular, using sterile swabs in order to calculate the epithet colonization index. All samples, whether deep or superficial, are subject to direct examination and culture on suboroclownphenical and suboroclownphenical actidion medium for 24 to 48 hours at 37 degrees Celsius. The identification of Candida species was carried out by Candida oxacolor gallery. Results. Global data. During the study period, 157 patients underwent at least one harvest from a normally trial deep site. Out of all patients, a total of 91 patients, or 58%, had negative deep samples from Candida, therefore excluded from our study. A total of 66 patients had at least one positive deep samples for Candida, of which 3 patients, or 2%, were hospitalized in the neonatal department, so excluded from our study. Therefore, a total of 63 patients, or 40%, were included in our study. Global distribution of deep samples positive for Candida. We have 69 deep samples positive for Candida, including 59 blood culture, 5 peritoneal fluids, 3 cerebrospinal fluids, 1 joint puncture fluid, and 1 valve vegetation. In order to calculate the epithet colonization index, a total of 315 peripheral samples were taken from urine, stool, mouth, nasal, and auricular. Cumulative incidence or calculated attack rate of systemic candidiasis cases. During the study period from January 1st, 2016 to December 31st, 2018, 26,323 patients were hospitalized in the aforementioned departments. 69 cases of systemic candidiasis were diagnosed. This gives us an incidence of 2.62 per 1,000 admissions. Global distribution of diagnosed systemic candidiasis. Each positive candida sample received corresponds to a proven case of systemic candidiasis according to the classification criteria of the European Organization of Research and Treatment of Cancer, EORTC. We report on figure the global distribution of the diagnosed systemic candidiasis. We have 59 cases of candidemia, 5 cases of peritonitis, 1 case of endocarditis, 1 case of arthritis, and 3 cases of meningitis. We report on figure the distribution of patients by age. The mean age of the patients in our study was 48.31 years. The median was 48 years. The distribution of patients by sex. Of the 63 patients, 41 were male, or 65%, and 22 were female, or 35%. The sex ratio is in favor of male patients, equal 1.86. Hospitalization services. In our study, intensive care units were the services most at risk for systemic candidiasis, with 32 cases diagnosed, or 46%. In second position came the hematology anti-cancer center departments with 18 cases, or 26% of all cases of systemic candidiasis diagnosed. In the medical services, we reported only 13 cases, or 19%. The lowest proportion of systemic candidiasis was reported in the surgical departments with 6 cases, or 9%. Risk factors. In our series, most of the patients presented with multiple risk factors and serious comorbidities. In our study, all the patients included 63 patients had at least 2 colonized sites, Colonization mainly concerned the buccal sites, urinary and rectal. Colonization with Candida is a risk factor that has been recognized as important in recent years. In our study, the prolonged stay greater than equals 7 days implies an increased risk of developing systemic candidiasis found in 53 patients. Exposure to broad-spectrum antibiotics is a risk factor for systemic candidiasis found in 58 patients. Antibiotic therapy was systematic since septic shock was the most common reason for hospitalization in 33.33% of our patients. In our study, 48 patients had a venous catheter, since the majority of them were hospitalized in the intensive care unit and hematology anti-cancer center. In our study, neutropenia was found in 18 patients. Malignant hemopathy was found in 18 patients, and chemotherapy was found in 20 patients. These three risk factors are very well linked. Our study did not place recent surgery as a major risk factor. We found it only in 8 patients, 12.69%. Colonization index. A total of 63 colonization indexes were calculated. According to the positivity cutoff value, colonization index greater than equal 0.5, the patients were divided into two groups. The first group included 14 patients, or 22.22%, were weakly or moderately colonized, colonization index less than 0.5. The second group included 49 patients, or 77.78%, were heavily colonized, colonization index greater than equal 0.5. Global distribution of species in deep samples. Candida albicans has traditionally been the most isolated species. However, a trend towards non-albicans species has been observed worldwide over the past 15 years. In our study, we obtained 75 isolates from different deep cultures. The identification of the species objectified the predominance of non-albican species, 45 isolates or 60%, compared to the Candida albicans 30 isolate species or 40%. Candida parapsilosis is associated more frequently with the presence of a center venous line and the use of parenteral nutrition than any other fungal species. 46% of the patients included in our study were hospitalized in intensive care unit and 26% in hematology anti-cancer center. 76.19% of them had a venous catheter. Candida tropicalis occupied third place among Candida isolated, with 8 isolates, or 10.66%. The different antifungals administered in the first line in the management of systemic candidiasis. In our study, voriconazole was the molecule mainly used in the treatment of systemic candidiasis, 29 cases or 42.03%, followed by cansidase used in the treatment of 24 cases of systemic candidiasis or 38.09%. Withdrawal of the venous line. In our study, 48 patients had a venous catheter. Removal of the venous catheter constitutes a factor of a good prognosis. The 75% survival rate is associated with the removal of the venous catheter. Non-removal of the venous catheter is associated with a high mortality, 71.87%. So, the non-withdrawal of the venous route is a risk factor for mortality. The calculation of K2 is a very significant, p equal 0.002. Global evolution and mortality. The outcome was favorable for 31 patients or 49% and unfavorable for 32 patients or 51%, resulting in death, resulting in a high mortality rate, highlighting the seriousness of these infections. Discussion. The main objective of this prospective bicentric study is to take stock of the epidemiology of systemic candidiasis and its evolution over time at the University Hospital Center and the Anti-Cancer Center of Batna, Algeria. In fact, most of the studies carried out of systemic candidiasis, either national or international, are multicentric and differ from one center to another, from one region to another, and from one country to another. In our study, the average age was 48.31 years. According to several studies, the ages most exposed to the risk of systemic candidiasis are often between 50 to 65 years old. Regarding to the distribution by sex, we noted a predominance of the male sex, 65%, with a sex ratio equal 1.86, which is consistent with all the data published so far. The most likely explanation is that the male population is more present among patients with major risk factors for systemic candidiasis. In our study, intensive care units were the services most at risk for systemic candidiasis, with 46% cases diagnosed. This rate is higher than that reported by TC at Bordeaux University Hospital, 35%, than that reported by SASU at Nimes University Hospital, 23.3%, and then that reported by TADEC at Nantes University Hospital, 27.7%. In second position came the Hematology and Anti-Cancer Center departments with 26% cases of all cases of systemic candidiasis diagnosed. Our result is far from that reported by TC and then that reported by TADEC. The intensive care and hematology anti-cancer center departments were the most affected by systemic candidiasis, as they had accommodated the patients who had the most risk factors based on what was found: venous catheter, neutropenia, hematological malignancies, chemotherapy, broad spectrum antibiotics, stay greater than equal 7 days. In the medical services, we reported 19% cases, which is far from the results reported by TCE at the Bordeaux University Hospital, 39%. The lowest proportion of systemic candidiasis was reported in the surgical departments, only 9% cases, relatively close to that found by TCE at the Bordeaux University Hospital, 13%. This low rate is related to the reduced number of samples received from the surgical services. In our study, we received 59 positive blood cultures, which corresponds to 59 cases of candidemia. So the proportion of candidemia isolated from all cases of systemic candidiasis diagnosed was 85.5%. Candidemia was the most common clinical form of systemic candidiasis. This high proportion can be explained by the frequent use of venous catheters, which is a risk factor found in 76.18% of our patients, especially that the species most isolated from blood cultures was Candida parapsilosis, a species closely related to to the use of venous catheters. In our study, we received 5 positive peritoneal fluids, which corresponds to 7.25% of our diagnosed systemic candidiasis. The low rate of Candida peritonitis isolated in our study can be explained by the fact that only 12.69% of our patients have undergone digestive surgery, which is a major risk factor for peritonitis caused by Candida. In our series, most of the patients presented with multiple risk factors and serious comorbidities. In our study, all the patients included had at least 2 colonized sites. Colonization mainly concerned the buccal sites, urinary and rectal. Colonization with Candida is a risk factor that has been recognized as important in recent years. In our study, the prolonged stay greater than equal 7 days implies an increased risk of developing systemic candidiasis. 84.12%, which is in accordance with several studies. Exposure to broad-spectrum antibiotics is a risk factor for systemic candidiasis, found in 92.06%. Antibiotics therapy was systematic since septic shock was the most common reason for hospitalization in 33.33% of our patients. The risk of fungal complications increases with broad-spectrum and prolonged antibiotic treatment. According to the study by Well, 1989, the number of different antibiotics was a most important prognostic risk factor for the expansion of candidiasis. The width of the antimicrobial spectrum and the duration of exposure are also correlated with the risk of fungal complications. In our study, over 60% of patients received more than 2 broad-spectrum antibiotic. In our study, 76.19% had venous catheters, since the majority of them were hospitalized in the intensive care unit and hematology anti-cancer center. The intravascular catheter used for parenteral nutrition supports the evolution of several species of Candida. Indeed, during the placement of the catheter, an adventitious trauma is created at the level of the entry door, causing a thrombosis. The ES multiplies near the point of entry of the catheter, then seeps into the vein and colonizes the pre-existing thrombus. In our study, neutropenia was found in 28.57%. Malignant hemopathy was found in 28.57%. Chemotherapy was found in 31.74%. These 3 risk factors are very well linked. In fact, malignant hemopathies cause a deficiency in polynuclear neutrophils, which are essential for body's defense against the dissemination of yeasts. Neutropenia can also occur when treating leukemia with cytostatic drugs or immunosuppressants used to prevent rejection of bone marrow transplants or kidney transplants. Our study did not place recent surgery as a major risk factor. We found it only in 12.69%. Mycological data. Candida albicans has traditionally been the most isolated species. However, a trend towards non-albicans species has been observed worldwide over the past 15 years. In our study, we obtained 75 isolates from different deep cultures. Predominance of non-albican species 45 or 60% compared to the Candida albicans 30 isolates or 40%, which is consistent with the several studies. Global evolution and mortality. The outcome was favorable for 31 patients or 49% and unfavorable for 32 patients or 51%, resulting in death, resulting in a high mortality rate highlighting the seriousness of these infections. In our study, we were able to demonstrate certain factors influencing the mortality rate. The Candida species involved. Candida parapsilosis is associated with a poorer prognosis with more than 44% of patients presenting an unfavorable outcome. The intensive care units presented the most mortality compared to other services with more than half of the overall deaths, 63%. Advanced age greater than equal 60 years is correlated with a poor prognosis and high mortality, 24 deaths or 75%. The lack of initiation of treatment was responsible for a high mortality, 23 deaths or 72%. The choice of treatment conditions the revolution. We noticed the most deaths with the use of azole, 6 deaths or 19%, then with the use of echinocandin like caspofungin, 3 deaths or 9%. Late initiation of treatment greater than 48 hours is associated with the highest mortality rate, 18.75%, while early initiation 24 hours results in the highest survival rate, 61.29%. Failure to remove the venous catheter is associated with a high mortality. Conclusion. Systemic candidiasis remains a serious and constantly increasing condition due to the increase in the population at risk. Their prognosis remains very poor compared to the severity of the condition, itself responsible for a high mortality rate, in our study 51%. Several risk factors predispose to the risk of systemic candidiasis. So, knowing the risk factors and patient profile is one of the means that direct us towards a preemptive diagnosis and allows the initiation of a preemptive treatment in order to reduce the death rate. Thank you for your attention.